I'm just going to introduce Phil Marino. It's a pleasure to have you here, Phil. Phil is a respiratory physician, and he works in the Lane Fox unit, and his special interest is non-invasive ventilation, weaning, and also is a pulmonary hypertension expert. But he's going to talk to us about non-invasive ventilation and weaning. Thanks, Phil.
Yes, thank you, Luigi. Tough act to follow, but I won't pull my punches or cut corners. But what I'm going to do is talk about difficult weaning. Hopefully, this will come up in a second. Oh no, there it is. Yeah, good. So essentially, I'm going to be talking about weaning, and there is obviously a role of NIV in that. But I mean, there's a wider field that I'm going to go through, and really sort of tackle what I try and face when it comes to weaning patients from mechanical ventilation. And so we're going to provide an overview of what weaning is, and there is a categorization, what influences it, what can we do to obviously help it, but also there are times when actually weaning sadly fails. So what is weaning? Well, it's successful withdrawal from mechanical ventilation. And this is sort of a categorization that was derived sort of 10 years ago, in fact. And sort of most of us would just look at the first step as simple extubation, but that is the simplest form of weaning. And then obviously you go up in sort of grades and severity. And it's estimated, depending on what cohort of patients you look at, that prolonged weaning, so people who have sort of failed 3 attempted spontaneous breathing trials or ventilated for over 7 days or both, that actually comprises about 10 to 20% of a critical care or ICU population. But obviously that's subject to the local environment. Weaning strategies, well, this is sort of a generic weaning strategy. This is intuitively what people will do when they have a ventilated patient that's admitted to the ICU. So what will we try and do? Well, we'll do a sedation trial, and then see obviously if they've got significant cognitive reserve to actually sort of be adherent to a spontaneous breathing trial, and there are various forms of spontaneous breathing trials. And then the spontaneous breathing trial is either successful, in which case you can proceed to extubation, or it isn't, in which case you then will consider resedating the patient, hopefully to a lower level, and then try and chip away at their ventilatory support. And if this process is taking days, then you will consider at some point potential tracheostomy insertion and sort of go through the iterative loop until you hopefully achieve sort of successful weaning, or you don't. And why is sort of weaning such a big issue? Why is duration of ventilation such a big issue? Well, I mean, actually, a lot of you are familiar with this already. The longer you're on ventilation, the longer you accrue morbidity and mortality. And these are sort of the morbidity issues that people face. And I think what's particularly fascinating, that even if you wean patients from sort of invasive mechanical ventilation, it's the final step, that there's a knock-on effect further down the line. You're far more likely to be in an assisted care facility 6 to 12 months, even though you would have been weaned successfully from mechanical ventilation. And obviously that's using an adjunct such as NIV. And what kind of factors most commonly play a role? Well, again, this is derived from a variety of sort of single-centre studies, case series, and these are sort of the main groups of diseases that result in prolonged mechanical ventilation and that increase in morbidity and mortality. And this is sort of beginning to give you the idea of when somebody comes to my weaning facility, these are some of the things I look for immediately. But more relevant, these are sort of the 7 things that I will run through in my head when I am referred and then ultimately receive a patient. And yes, it's very formulaic, but you know what? It can actually help in terms of discriminating what's going on and actually getting that patient further forward in terms of successful weaning from mechanical ventilation. So I am going to sort of go through them sort of one by one. First of all is obviously, is there a parenchymal lung or chest wall component? I mean, obviously these are the things that we routinely look for, but surprisingly these are still issues that I will be confronted with when patients are referred to my weaning facility. And so, you're trying to optimise the underlying lung disease. Is there a physical restriction? And in cases, we do end up having to drain pleural effusions to move people forward. But that can be have a dramatic impact on weaning. obviously one other sort of pleural restriction, but it's not really within the pleura, is BMI, which is another thing that you have to think of, but you can't actually modify there and then. Coronary artery disease, cardiac disease of any form, this is one of the biggest things that keep people wedded to mechanical ventilation. One of my colleagues has a maxim, and it's not based on hard data, but he finds it very difficult to accept people who have got significant LV disease, because in his experience, the likelihood of them being weaned is very small. Now, I can speak with another hat on, because in my previous existence, I worked at the Brompton for 5 years as an intensivist. And actually, if you do optimise the cardiac disease, you can move these people forward. So, but you have to be fairly bullish in what you're going to do. Sort of diuretics, ACE inhibitors, beta blockers may help, but quite often you're having to go to more sort of interventional aspects of care in order to move that patient forward. And in some cases, it's restoring coronary perfusion. Some cases, it's offering cardiac resynchronization. More extreme cases, and this is obviously something that would be more familiar in cardiothoracic centres, you need to change the underlying valve, replace it in some way or another to actually sort of allow sort of normal cardiac output, which allows sort of, the person to move forward in terms of their weaning, because obviously these conditions are largely associated with low cardiac output states, arrhythmias, pericardial effusions. With my other hat on, I unfortunately see people who usually have pulmonary hypertension, not in the idiopathic realm, but usually in association with other conditions, and quite often sort of just supporting the pulmonary vasculature and helping the RV can move that patient move forward. I do think of neurological, and that's because obviously you've seen with the ECMO patients there are sequelae that people can endure from prolonged, from severe respiratory failure. So it's looking for obvious causes in the for neurological insult. The one thing that we see a lot of in my particular institution, which is at Lane Fox at St Thomas's, is obviously the context of neuromuscular disease or neurological injury. And I mean, in some cases there's immunotherapy that you can use to reverse that process, but that tends to be, not an immediate reversal of the condition, it's a stabilisation and then hopefully regression, but it really then sort of gives you a benchmark of how long they're likely to be in terms of weaning and how much they're going to need in terms of allied sort of interventions such as physiotherapy, dietetics, OT. It gives you an idea of sort of the duration of the problem that you're potentially going to face. Abdominal, well, we always get fixated on the chest, but remember your tummy can get splinted from below, and we have seen people with intra-abdominal conditions and intra-abdominal catastrophes, particularly things like pancreatitis, bowel tumours, who have resulted in intermittent pseudo obstruction. You treat the underlying problem, they move forward. Liver patients, cardiac and liver patients, predominantly liver patients, they have ascites, you treat the ascites and they can move forward. There are case reports of draining ascites even in sort of people with decompensated cardiac diseases and an extreme form of management, but again it's helped sort of reduce intra-abdominal pressure and allow the diaphragm to work. You treat the liver disease, and in some cases, treating endocrinopathy as a cause of sort of muscle weakness. We had one chap who was treated as sort of an undiagnosed malignancy at another institution for several months, and then somebody just lo and behold did a thyroid function on him, just out of the blue, and he was thyrotoxic. We treated the thyrotoxicosis in the form of having to do a thyroidectomy, and we actually managed to get this guy off mechanical ventilation completely. But this is a man who'd been labelled as an undiagnosed undiagnosed malignancy stroke infectious process, and actually all he was a hypothyroid. So, it just shows you that, that even simple tests can give you enormous benefits. And you've got to think, you've got to think through the sieve. You can't assume that everything has been done. Because we're all human, we're all capable of sort of overlooking even the smallest of details. But this is why I choose to go through this algorithm. Drugs are a big factor, and we all do, in this critical care setting, inadvertently sort of use sedation, sometimes excessively, often because we have no choice, but it can prolong mechanical ventilation. And one of the great sort of issues is the use of benzodiazepines, particularly in midazolam, in the context of renal dysfunction. I mean, if you have, good going renal failure, needing renal replacement therapy, and you've been on a midazolam infusion, it can take you up to 2 weeks for that midazolam to leave your system. And that's 2 weeks where people could just say, oh, well, we've done the CT's fine, we looked at everything else, this patient just isn't going to do. And actually, you do have to pull back and give people time. Quite often, giving people sort of 5, 7, 10 days and let the midazolam wash out. And it's like a Paul McKenna episode. They're back in the room. They're awake. They're actually beginning to interact. So you've got to give time with a lot of these things. It's not, you can't just you can't expect it to sort of turn around in 1 or 2 days. With sedation, you do have to look at the pharmacokinetics and actually appreciate how the underlying pathology is interacting with that to see if that's a contributing factor. And there is obviously sort of psychological issues. People who develop critical care sort of psychoses or psychological disorders, that can have an impact on their weaning, because obviously that can affect their respiratory effort, and you do have to tackle those as well. And then finally, we look at the ventilator. What you'll often find is that there is some degree of sort of misinteraction between the patient and the ventilator. The most common one that we see is neuromuscular patients, where the trigger on the ventilator is set at a higher level. Now, for you or I, that wouldn't be a problem, but somebody who's got inherent neuromuscular weakness, if you set the trigger too high, of course they're not going to trigger breaths, they're not going to breathe spontaneously. So you've got to look at the triggering, you've got to see if they're giving them sufficient time to breathe in. You've got to make sure that you're giving them sort of sufficient pressure. And then you don't want to be giving them too many inappropriate breaths if they're on a sort of pressure control mode. You've got to see what the person's doing beneath that. So there are a whole variety of things that you've got to assess in terms of the interaction to see if they can move forward. And sort of this reflects sort of the tests that we would sort of either expect to have done or would complete while patients are in our weaning facility to actually make sure that we haven't overlooked the slightest detail in terms of moving these patients forward. And more importantly than that, actually, as I said, the whole process of weaning isn't sort of just clinician-led or medic-led. It's multidisciplinary. So in the neuromuscular cohort, we're very dependent on our physical therapies and dietetics. Obviously, with people who have been in critical care for a long time and have psychological issues, we are very dependent on things like counselling, psychology and psychiatry, and it's getting all those people under one roof, which we're fortunate to have, to assess those people. When every morning we have a multidisciplinary meeting where we go through the patients with all the various parties there, and we look at all these issues in tandem and see what we should be tackling collectively to help move the patient forward. And it's the cumulative effort that helps move these people forward rather than the occasional blinding result that comes out of nowhere. In terms of adjuncts, well, I'm not actually going to pore over this in detail, because really, I've been asked to look at difficult weaning, and my interpretation of that is what can you do to sort of divorce people from invasive mechanical ventilation. And at the moment, there are really sort of 2 adjuncts that people have used. There's NIV, which we're all familiar with, and also high-flow nasal oxygen, which we're becoming increasingly familiar with. And the rule of sort of principle here is that they help reduce work of breathing, so you can translate them from being invasively ventilated to non-invasively ventilated, and therefore hopefully moving them forward. In terms of NIV, I'm really only going to look at one study, because there are a whole raft of single-centre and sort of multi-centre trials with very small numbers. But this is sort of a Cochrane analysis to look at all that data in one go. So this is from a Canadian group, and they sort of identified 16 sort of single-centre or multi-centre randomised controlled trials. And as you can see, nearly 1,000 patients, but very heavily skewed by a COPD population. And what the analysis showed is that if you extubate people onto NIV, well, actually, you can reduce length of stay. You can shockingly reduce VAP. You won't have you reduce rates of intubation and tracheostomy, and potentially reduce mortality. But this data is very heavily skewed by COPD. So what do I draw with this? Well, actually, in COPD patients, extubation on NIV can be a useful adjunct in terms of weaning people from invasive ventilation. The only other 2 signals where that may have been appropriate, but the numbers are small, are neuromuscular and obstructive sleep apnea. Nasal high flow oxygen, well, again, this is an increasing tool. There's recently 2 trials that have come out in New England and JAMA looking at how it can be used to prevent intubation and sort of reduce mortality. We're looking at the other way. So can you extubate people onto it to achieve the same effect? And essentially, it's very high oxygen air flow into the respiratory tract, really washing out the dead space with oxygen, but also offering some degree of PEEP. And really, in the last couple of years, there have only been 2 trials, and they were both single centre and university hospitals that have looked at this. And this is from Israel, and this is a 63 patients on ICU. And as you can see, they were randomised to either nasal flow, high nasal flow, or rebreathe. And actually, you got better oxygenation indices with high nasal flow oxygen, which is, unsurprising, and more ventilator-free days and less intubation, but no difference in terms of length of stay or mortality. This is, another single-centre study from Italy, this time 105 patients looking at Venturi, and essentially sort of the same, with the same data, but again, results, but no impact on mortality. Just to remind you that if you do have difficult to wean patients, there are sort of 5 sort of specialist centres that are around the UK that can deal with these patients. And the reason why I sort of highlight these is not so much in the context of weaning, but when weaning fails, because inevitably we can't wean everybody from mechanical ventilation. There's about sort of 2 to 5% of patients who can't. And then we're looking at long-term invasive ventilation or non-invasive ventilation in these groups. And it's really designed to take what we're doing in the critical care environment, but into the community. And that can be done, like I said, either by a tracheostomy invasively or non-invasively. And tracheostomy patients don't have to be continuously ventilated. They can be ventilated at night. And sort of the first sort of wave of that was with the polio epidemics in terms of non-invasive ventilation. But now with sort of more positive pressure devices, we're obviously devolving sort of increasing number of patients into the community. And the community could be the home, the actual home, a nursing home, or some sort of other medical facility. And to do that, though, you've got to make sure that there's an appropriate infrastructure. And this is really what we're ensuring, that first of all, there's medical stability. There has to be a care input, and that's either family or formal care package brought into by the local health authority. And there has to be an extensive sort of clinical sort of input as well, from not just local GP, but chest physicians, sort of, as you can see, allied health professionals as well. It's only going to get more common as a problem because obviously our population is getting older, it's getting larger, and it's accruing more comorbidities. And that's going to provide sort of particular challenges because obviously we live in a time of rationalisation, or should I say careful financial management. So how can I summarise this? Well, sorry for the run through, but essentially weaning is a multidisciplinary approach, and you do have to have a sort of an algorithm for tackling all the various elements that I've shown that could be contributing to that. In terms of adjuncts, well, NIV, there's certainly a place for it in terms of extubation, early extubation, COPD patients, not so much so, and to a lesser degree in neuromuscular and sleep apnea. High nasal flow, we're still evaluating. Weaning units really are there to help you in terms of tackling the more prolonged ventilated patients and the complex ones that won't sort of progress with simple strategies. And obviously all of us are going to face the challenge in terms of these patients appearing on our units and then having the facility to manage the increasing number that we're going to see. Thank you very much.